Hi, I'm Adolphe Edward. I'm the Chief Executive Officer of El Centro Regional Medical Center. Thank you for joining us today. We have two awesome speakers. Let me start by introducing them. Our first COVID-19 expert is Dr. John Redd. Dr. Redd is the Chief Medical Officer within the Department of Health and Human Services, Office of the Assistant Secretary for Preparedness and Response. Thank you for being here, Dr. Redd.
It's my pleasure to be here. Thank you.
Captain Hicks is the Chief Medical Officer for Vaccine Task Force and a medical epidemiologist in the Division of Health Quality Promotion within the National Center for Emerging and Zoonotic Infectious Diseases, a center in the Center for Disease Control and Prevention. Thank you for joining us.
Thank you. It's an honor to be here.
Well, let me just prepare by giving a little bit of a background. Today, we'll be discussing the future of SARS-CoV-2 variant vaccines and the treatment of COVID-19, plus the vital role for monoclonal antibody play in the fight against COVID-19, something that my community actually was very positively affected with and helped us immensely. Vaccines prevent the spread of COVID-19 and will help bring the pandemic to an end. COVID-19 vaccines are safe and effective. While vaccines are playing a vital role in the driving down the number of cases, monoclonal antibodies continue to be a critical tool for improving outcomes for people who became infected with SARS-CoV-2. And like I said, my community really got affected positively with such monoclonal antibody availability. Monoclonal antibodies have been authorized for emergency use by the FDA to treat patients with mild and moderate COVID-19 who are at high risk for developing severe symptoms. In May, the FDA expanded patient eligibility criteria for COVID-19 monoclonal antibody treatment, giving clinicians greater latitude to exercise clinical judgment in identifying high-risk patients and referring them for IV infusion treatment as soon as possible, or in some cases, treating patients in their office with subcutaneous injection. First question goes out to Dr. Redd. Dr. Redd, can you briefly explain how the COVID-19 environment has changed since the first monoclonal antibody treatment received an emergency use authorization? And how has our knowledge about the effectiveness evolved as well? And can you comment on utilization of clinical judgment in high-risk patients' identification and treatment? We'll take it one at a time. Over to you.
Thank you very much, Dr. Edward. And I want to say what a pleasure it is to be here. And I'm very happy to take up this important topic with you and with Dr. Hicks. So first of all, in terms of what's changed since November, which as you well recall was when the first emergency use authorization or EUA was sent out for monoclonal antibody therapy. So initially, which was November 9th, the first monoclonal antibody therapy that was authorized by FDA was bamlanivimab. And it was for what we call monotherapy bamlanivimab or bamlanivimab alone. And subsequently, there was authorization of a combination product, which now has the brand name REGEN-COV, made by the Regeneron Corporation, which is a combination of casirivimab and imdevimab. Subsequently, we added to the Lilly product the authorization of etesevimab. And the reason why we have the FDA authorizing combination therapy is because, as we've seen with the development of the variants in the United States and the rest of the world, the SARS-CoV-2 virus is capable of evolving and of adopting to its new circumstances and new situations. And we've seen that. In fact, the variants which have come out in the United States and elsewhere are an example of evolution in action. And it's because of that that the FDA did change the authorization for Eli Lilly Company to authorize only the combination therapy, so which is bamlanivimab and etesevimab. And this was a very, very important development. So that is the first answer I've got, is that's actually, I would say, been the major change since we started this together.
Excellent. And Dr. Hicks, building on that, why are vaccines seen here as critical tools in the present day fight against COVID-19, particularly as new variant emerges and I know that we're all affected by the new variant, as Dr. Red was saying. What's your thoughts?
Yeah, I'm so very grateful to have this opportunity to speak about vaccines. We're very fortunate to have numerous effective vaccines to help prevent COVID-19. All three of the COVID-19 vaccines currently authorized for use in the United States to protect against COVID-19, including severe illness and clinical trial settings. And we also have real world data from vaccine effectiveness studies that have shown that these vaccines reduce the risk of COVID-19 and its potentially severe complications. And then what I also want to mention is that our vaccines provide protection against asymptomatic infections, which can reduce the spread of disease overall, helping protect people around you and get us back to normal or closer to normal. And while the vaccines are working quite well, some people who are fully vaccinated against COVID-19 will still get sick because no vaccine is 100% effective. So as a result, vaccine breakthrough cases are absolutely expected. We're currently tracking known variants very, very closely to ensure that our vaccines are working. And so far, our data indicate that FDA authorized COVID-19 vaccines can protect against Delta and other known variants. But we're still learning about this variant and anticipate there will be other variants that emerge. If we identify that escape variants are occurring, if they escape our current vaccines, new vaccines can be tailored to target those concerning variants.
Excellent input, Dr. Hicks. Thank you. Dr. Red, I just want to maybe come back again and have you emphasize for us. Am I hearing this clear? Is it clear that the monoclonal antibodies are effective against the Delta variant and other variants?
Right, that's a perfect question. And in fact, we've been getting that question quite a bit. As we know now, the Delta variant is now the most common single variant in the United States. So if someone has COVID-19 that has been caused by the Delta variant, the really good news is that both of the products available in the United States treat it, and they treat it quite well. So either the Regeneron product or the Lilly product both treat the infection extremely well, and we continue to urge everyone who ends up with a COVID-19 diagnosis to consider getting monoclonal antibodies very, very quickly. And as you know, Dr. Edward, when we work together in El Centro to great effect, we put a lot of emphasis on getting people in early. So I appreciate that question very much.
Outstanding. Thank you both. So the question is maybe for both of you. Some vaccinated people, for example, people with compromised immune system, will not develop adequate immune response. So what do you recommend for those individuals?
This is a question we're receiving quite frequently. And I want to first emphasize that the currently authorized COVID-19 vaccines are not live vaccines and therefore can be safely administered to immunocompromised people, including people with HIV or other immunocompromising conditions or those who are taking immunosuppressive therapies. So getting vaccinated is the safest way to build immunity to protect against COVID-19. But as you mentioned, data suggest immune response to COVID-19 vaccination might be reduced in some immunocompromised people, including people taking medications like mycophenolate or rituximab, people who are receiving chemotherapy for cancer, those with hematologic cancers such as chronic lymphocytic leukemia, and those who have received stem cell or organ transplants. So people with immunocompromising conditions should be counseled about the potential for reduced immune responses to COVID-19 vaccines and the need to continue preventive measures. But I would mention that monoclonal antibody treatments can provide an additional safety net in these patients for whom vaccine effectiveness is a concern.
Yeah, thank you very much, Dr. Hicks. You know, I couldn't agree more. There's no question that the best way in the United States and around the world to combat COVID-19 is for people to get vaccinated. However, we do know that we'll continue to have a need for the monoclonal antibodies. Nothing could make me happier than in the United States to see that need continue to go down and down and down. That's what we all want. But we know that that we're going to continue to need it. And we've seen that with the unfortunate uptick in outbreaks that are related to the Delta variant, such as in South Central Missouri. But I wanted to get back to one aspect of the variants that we get asked a lot. You know, the United States still has a fairly substantial portion of the beta and gamma variants. And the issue with monoclonal antibody treatment is that while the Regeneron combination product treats beta, gamma, and delta, the Lilly product is not effective against beta and gamma. So if you've got delta, either of the two products will help, or if it's an area of the country where delta is the most important variant, either of the two products will help. In other locations, we recommend that folks get the Regeneron product. So it really gets back to the point, Dr. Edward, of why we need to keep track of variants in the United States. And the reason why it's so important to get vaccine is not just an individual one. Every time somebody has COVID and they pass it on to someone else, the virus is getting another chance to mutate. And that's how variants end up occurring. And so to every extent that we can slow down transmission, we will get fewer and fewer variants. And that's really the way to end these variants. And so that's what I hope we all can continue to do, and primarily through vaccination. But we're very grateful that we have the safe and effective treatment of monoclonal antibodies in case they're needed.
Dr. Ed, that last point that you made is extremely very important that we share it with everybody. Let me maybe stay with you for another question. The FDA recently has updated the emergency use authorization fact sheet to include guideline on subcutaneous administration of the monoclonal antibody. How do you foresee this will impact clinicians and patients, and when can clinicians use this option for treatment?
Yeah, thank you. So the subcutaneous, it's a measure that we're all familiar with. If you've had someone in your family who takes insulin for diabetes, for example, that's a subcutaneous injection. And the Regeneron product, brand name RegenCove, is authorized by FDA now to be given either subcutaneously with 4 injections, and that's generally 2 injections in the abdominal fat pad, where you're used to people getting a diabetic shot, and then 2 injections in either the front part of your thigh or the back part of your upper arm. The recommendation is that subcutaneous administration be used if getting it IV will cause too much time to elapse before the patient can get it. So in other words, if it's going to be a burden, or if someone has to travel to a center. And I'm really, really excited about subcutaneous. Earlier in my career, I practiced for years on the Navajo Reservation in northeastern Arizona and northwestern New Mexico. And of course, that's a part where people live in locations that are really separated broadly from one another. Actually, Dr. Edward, down where you practice also, there are loads of people who live separated from one another. And I feel like the subcutaneous mode of giving RegenCove is going to be really important, because what I imagine is that you'll be able to have the product get to the patient, and that is that's the best thing we could possibly do. So we're really enthusiastic about giving the product subcutaneously in locations where intravenous is not immediately available. So I'm often asked about this, and one way to look at it is to think of an individual person. Like you're looking at somebody and she's got COVID-19 diagnosed, and you say, well, would you rather have IV or subcutaneous? But I don't actually think that's the way to look at it. The way that I look at it is that the addition of subcutaneous administration is expanding the range of people whom we can treat. And we've had loads of doctors' offices and other places be very interested in this method. So think of this, especially now that we have rapid tests, such as we used extensively in El Centro. So you go to the physician or an urgent care or what have you. You go with problems that are compatible with COVID. You get a rapid test, and you can get the subcutaneous injection, and you're out in an hour. So it's really very convenient. And if it's okay, I did want to turn back to a couple questions asked before. The first one is about the effectiveness of the antibodies. And we've seen very, very consistently all around the country that the antibodies, monoclonal antibodies, reduce the risk of hospitalization or severe COVID by 70 to 80%. And that's in people with risk factors. And that is really substantial. So not only do they make the individual person feel better more quickly, they also lead to fewer hospitalizations. And that's helpful for lots and lots of reasons that even go beyond just individual health. The other change that the FDA has made in regard to the emergency use authorization is that the FDA has really broadened the number of people who are eligible to receive monoclonal antibodies. So now anyone 12 years of age or older who has confirmed COVID-19 is potentially eligible for monoclonal antibody treatment. The main criterion is that the person has a risk factor that makes them at risk for having a worse outcome. And the really nice thing about the change in the FDA emergency use authorization is that the risk factor is now judged by the treating clinician. So it is exactly the same as when you see your clinical provider in other settings. You talk to the doctor or other provider, they know you, they make a judgment about your risk factors, and then together you make the decision to try to get monoclonal antibody treatment. So it's really, it's much less limiting than it was when these products were first out, and I really want for everyone to understand that.
Dr. Red, actually, we saw the results here in El Centro, and you're spot on. I want to ask maybe both of you something that started out with Dr. Hicks. How do we maintain and expand the public trust in vaccines and treatment like monoclonal antibody? Because it's important for my community as we share that with everybody.
Yeah, this is absolutely crucial. Vaccine confidence is the trust that patients or healthcare providers who administer vaccines and the healthcare systems have in the vaccines. And perhaps the same can apply to confidence in other treatments like monoclonal antibody therapies. We know that the most trusted relationship for information is the one between providers and patients. And transparency is key here. We can build and earn trust in the system through clear, accurate communication and by empowering you, the healthcare providers, to have empathetic vaccine conversations with your patients and to engage with communities and individuals in an equitable and inclusive way. And we also want to make sure that that language is respectful. I want to just also mention at the very end of my comments that trust is a process and not an end state. So think about it more as building trust through each and every conversation.
Yeah, I agree with everything you've said. You know, in the case of monoclonals, we had a lot of issues to overcome, frankly. But we found that when we get out and when we talk to providers and talk to patients, there is extremely high acceptance. So what we've done is, much as Dr. Hicks was saying, is we try to make sure that the evidence gets out to people. Obviously, we want for people in the United States and around the world to make their own decisions. You're right that people do trust their physicians and like to talk to them about these products. So we've really tried to hit that on all fronts. And I would say that if people want more information, there are a couple of good websites to go to. The first is www.phe.gov. That stands for Public Health Emergency. And that is the ASPR website. And that's got loads of information on monoclonals and links to vaccine as well. And then secondly, combatcovid.hhs.gov is another great website for people to go to if they want further information.
Very good input from both of you. Thank you so much. Let's turn our attention to patient access to treatment. Maybe I'll send this question to you, Dr. Red. How will possibly new forms of monoclonal antibody administration and therapeutics increase patient access to treatment? I'll be honest with you, I saw it here in El Centro when we opened up the tent. That was so good for us to have the availability of the resources. Your thoughts?
These antibody treatments have been procured by the government of the United States on behalf of all the people in the United States, and they are intended for equal, equitable, and easily accessible use to everyone all across the country. And we have kept that as a sacred principle this whole way through. They are intended for everyone who needs them. And I would want to mention that now, happily, they are also in very, very sufficient supply. So, in fact, literally any clinical setting in the United States that would find it appropriate to give monoclonal antibody treatment can order them. And they no longer need to be allocated. They are certainly not being triaged, as we say, by state. So what I would encourage, any site that would like to administer monoclonal antibodies can email COVID-19 Therapeutics, that's all one word, COVID-19 Therapeutics at hhs.gov. And we've got more than sufficient supply, and we would like for everyone to use it. So I really encourage people to email COVID-19 Therapeutics at hhs.gov.
And Dr. Red, I want to add that when we called you, you were able to bring our very poor community here, predominantly Hispanics, the monoclonal antibody for treatment within a matter of hours of the conversation we were having with you. So we can't thank you enough for helping our community. So anybody out there, please take advantage of the availability of this treatment and rush to getting it out to your community as well. Dr. Hicks, let me come back to you. Another question. As we discussed earlier, the effort to help many Americans and possibly get vaccinated is in full swing, and we're very excited about that. But what piece of advice would you give clinicians as they kind of counsel their high-risk COVID-19 patients during this critical time? You kind of a little bit addressed some of that, but if you can give us that emphasis, what would that be?
Absolutely. I want to come back just to the message that healthcare professionals are patients' and parents' most trusted source of information on vaccines. So it's really the healthcare professionals who are going to be able to help make a difference in terms of vaccine recommendations to their patients. So your answers to questions matter and will help your patients and parents make an informed decision about getting a COVID-19 vaccine for themselves or their children. I'm going to give you 5 steps to having effective COVID-19 vaccine conversations with your patients. And first, it's always important to lead with listening. And I think this is the case for a lot of our medical interactions. And so I want to just start with that. But second, use patient-centered communication techniques such as asking open-ended questions to promote a dialogue. Third, respond to their questions and concerns with empathy. Fourth, and most importantly, this is the one I want to emphasize, give your strong recommendation for COVID-19 vaccine and vaccination tailored with reasons particularly important to each patient or parent. What will matter to them? And then fifth, perhaps is where I can insert my favorite recommendation, end the conversation by encouraging patients to take at least one action. And my favorite action would be to encourage your patient or parent to go ahead and schedule a vaccination appointment.
Thank you very much for that information and for the clarification. I'm going to go to Dr. Red and ask, fall is coming and winter. What do you foresee for the U.S. as we enter fall and winter? And how can the providers, all the providers that are out there, keep abreast of everything that NIH, FDA, CDC, and others are putting out in terms of treatment decisions?
Well, I can say, first of all, that what I most dearly hope is that vaccination will continue to progress in the United States and that we can have as minimal a fall COVID-19 season as possible. So that is by far the best outcome we can all hope for. However, we know that people tend to go back indoors in the fall, and that's why flu tends to come up in the fall. So I think all of us are anticipating that we will have an increase in the fall. We're hoping to mitigate it and reduce it with broad use of vaccine. But we do have a lot of really interesting developments that we hope are on the table for the fall. So one possibility is that we all hope that eventually there will be an oral treatment, a pill, for COVID-19. And we're planning around that eventuality. So we are very, very hopeful that right now the big effort that we make for providing monoclonal antibody, either infusion or subcutaneous injection for people who are early in their COVID. We hope fervently that eventually we'll be able to talk about having oral treatment for it. And that we would all like to have that, so it's more convenient. It's certainly a lot easier to transport pills than it is to transport a liquid. So that's what we hope for there. We also hope that we don't have development of any variants that are worse than what we have now, but obviously we can't count on that. So, I lead a team here, and one thing I'm sure they get tired of me saying is I try to tell them, let's start trying to solve October's problems now. And so we are trying very, very hard to look ahead at issues that are going to come up.
This is fantastic. Thank you, both Dr. Hicks, Dr. Red, for joining us today, for the time to talk about this very critical matter, not just for any institution, but for the whole country and maybe the world. Thank you again, all of you, for joining us on this live stream.
Well, thank you very much, Dr. Edward. It's been an absolute pleasure. I look forward to the next time. Thank you.
Thank you.
Thank you.
Thank you, Dr. Hicks. We hope that this conversation has provided you with some helpful information, and we encourage you to visit combatcovid.hhs.gov to learn more. You can have your patients call 1-877-332-6585 for English, or 1-877-366-0310 for Spanish to find infusion sites near them. Thank you again, and have a wonderful day.